Hi, I'm Dr. Shabana Khan for the Joint Telepsychiatry Toolkit by the American Academy of Child and Adolescent Psychiatry and the American Psychiatric Association. Today, I will be discussing legal and regulatory updates in the context of the COVID-19 pandemic. This video will build on the content of our first Legal and Regulatory Considerations Toolkit video with a focus on key changes that have occurred at the federal and state level relevant to pediatric telepsychiatry. Telepsychiatry has allowed Americans to safely continue to receive mental health care during the pandemic while maintaining social distancing and reducing the risk of exposure for both patients and healthcare professionals. Prior to the pandemic, legal and regulatory hurdles often limited the legitimate practice of telemedicine, including telepsychiatry. The rapidly rising rates of COVID-19 across the United States, the national public health emergency, and state-by-state emergency declarations and executive orders served as an impetus for changes at the federal and state level, for which the telemedicine community has been advocating for decades. Prior to initiating telepsychiatry with children and adolescents, psychiatrists should consult federal and state laws and regulations prior to and during the pandemic. State Medical Licensing Board regulations, Drug Enforcement Administration or DEA policies, as well as organizational and practice-specific policies and procedures. It's important to note that the flexibilities that we've seen at the federal and state level during the pandemic, for the most part, are temporary, and unless specific statutory or regulatory action is taken to make these permanent, we will spring right back to prior state. Legislators, regulators, and policymakers are in the process of determining which of these changes or flexibilities are appropriate to be continued post-pandemic. This highlights the importance of advocacy. The American Academy of Child and Adolescent Psychiatry has done a significant amount of advocacy at the federal and state level to help ensure that those flexibilities that are appropriate to continue long-term are made permanent. As child psychiatrists are navigating these changes, it is important to consider both federal and state rules, as they may not always align. We will discuss flexibilities during the COVID-19 pandemic related to telehealth and licensure, controlled substance prescribing, and privacy and security. On January 20th, 2020, we saw the first confirmed case of COVID-19 in the United States in the state of Washington. On the 31st, the Secretary of the Department of Health and Human Services declared a national public health emergency. On March 11th, the World Health Organization declared the COVID-19 outbreak a pandemic. March 13th, the President declared a national emergency, and the Centers for Medicare and Medicaid Services issued the first set of regulatory waivers. On March 16th, the DEA waived the requirement for an in-person examination before prescribing a controlled substance via telemedicine. On March 17th, the HHS Office for Civil Rights announced that it will not impose penalties for the use of non-HIPAA adherent technologies. On April 26th, HHS extended the public health emergency through July 25th, 2020. And on July 25th, HHS extended the public health emergency for another 90 days. With respect to telehealth and physician licensure, we will begin by discussing considerations prior to the pandemic. The general rule is that a physician must be licensed in the state where the patient is located at the time of the telehealth encounter. The physician must also adhere with the state's Medical Practice Act as well as practice standards. There are special rules for care provided through the Department of Veterans Affairs and the U.S. military. There's the Interstate Medical Licensure Compact, which is an agreement between 29 states, DC, and Guam. And some states have exceptions relevant to telemedicine with state-specific nuances. Finally, most states have made changes to licensure requirements in the context of COVID-19. The Interstate Medical Licensure Compact is an agreement between 29 states, DC, and Guam, which offers a voluntary expedited pathway for licensure. Compact states have the ability to share investigative and disciplinary information. While the Interstate Medical Licensure Compact may, in some instances, expedite the time to licensure in some states, A physician must still obtain and pay the full fee for a medical license in each relevant compact state, pay an additional administrative fee, and keep up to date with regulatory, continuing education, and other requirements of the relevant states. A physician must hold a full unrestricted license in a compact state. The significant expense, time, and documentation burden of cross-state licensure can limit the potential of telemedicine. Some states have exceptions such as consultation, follow-up care, limited licenses or registration for telemedicine, or reciprocity agreements. A consultation exception allows an unlicensed physician to provide a peer-to-peer consultation to a physician licensed in the state. A follow-up care exception allows an unlicensed physician to provide follow-up care to an established patient without being licensed in that state. Some states have limited licenses or special registrations for telemedicine care only. And finally, some states have bordering reciprocity, in which an out-of-state physician licensed in a bordering state can practice medicine in that state without a license. For states that do have such exceptions, there are state-specific nuances with no two states alike. In the context of the pandemic, many states have temporarily waived or modified licensure requirements generally, waived licensure requirements specifically for telehealth, and/or expedited licensure for retired physicians. These flexibilities are often tied to state-specific executive orders and emergency declarations, and thus are expiring at variable times. This patchwork of state-by-state licensure waivers are complex to navigate, and they may impact a physician's ability to provide continuity of care across state lines if they abruptly end. This also makes it challenging for healthcare professionals who are seeking to help bridge the gap by providing care in states they are not licensed in that have high COVID-19 rates and workforce shortages. The Federation of State Medical Boards website lists state-by-state licensure waivers and flexibilities and is updated regularly. Licensure was a pre-existing hurdle prior to the pandemic, and the pandemic has just further highlighted the challenges. Legislators, regulators, and state boards of medicine should consider additional action and long-term solutions to streamline licensure across state lines, as this is a long-standing issue that extends beyond the crisis. Federal restrictions on the prescription of certain medicines through telemedicine may complicate the practice of telepsychiatry with children. The Ryan Haidt Online Pharmacy Consumer Protection Act was passed in 2008 with the goal of combating rogue internet pharmacies, which were proliferating in the 1990s, and dispensing controlled substances without patient contact or physician oversight. This act has had the inadvertent effect of limiting the legitimate practice of telemedicine. This act requires, among other things, that a practitioner conduct at least one in-person medical evaluation of a patient before prescribing a controlled substance. There are 7 practice of telemedicine exceptions. However, these exceptions are very narrow and they don't apply to most current practices of telemedicine. One telemedicine exception is a special registration. It's been 12 years and the DEA has not yet defined or activated the special registration, despite Congress and the President setting a deadline of October 24th, 2019 for the DEA to promulgate final regulations and activate this special registration. The requirement for an in-person evaluation outside of these very narrow telemedicine exceptions has been a significant obstacle to the legitimate practice of telemedicine. Examples include the use of telemedicine for medication-assisted treatment for opioid use disorder, or stimulant medication for a child with attention deficit hyperactivity disorder who is evaluated by telemedicine. The telemedicine community and several national professional organizations have been advocating for the DEA to remove this in-person requirement if a practitioner is acting in his or her usual course of practice and issuing the controlled substance for a legitimate medical purpose. The second Ryan Haidt Act telemedicine exception is the declaration of a public health emergency by the Secretary of HHS, which occurred in January 2020. In response to this declaration, the DEA has adopted policies that allow DEA-registered practitioners to prescribe controlled substances without an in-person examination. On March 16, 2020, the DEA issued guidance indicating that during this public health emergency, the DEA is allowing registered practitioners to prescribe controlled substances to patients without an in-person examination if the prescription is issued for a legitimate medical purpose, the practitioner is acting in his or her usual course of professional practice, the communication is conducted via live interactive audio-video, and the practitioner is acting in accordance with federal and state law. Though this change made at the federal level has been helpful in some cases to provide care to patients during the crisis, practitioners must also comply with practice standards and other applicable federal and state laws and regulations, which don't always align. Regulators and policymakers should consider long-term solutions to prescribing hurdles that will align with diversion prevention efforts and the legitimate practice of telemedicine, both of which are important. On March 23rd, the DEA issued guidance regarding DEA registration requirements across state lines during the public health emergency. DEA regulations typically require that a practitioner obtain a separate DEA registration in each state in which he or she dispenses a controlled substance. In this guidance, the DEA notes that for the duration of the public health emergency, the DEA has granted an exception to this requirement of a separate DEA registration in each jurisdiction. Obtaining a separate DEA registration and having to list a unique physical address in each state has been a longstanding hurdle to provide telehealth across state lines. The DEA has also released additional guidance on the use of phone or audio-only technologies for the prescribing of buprenorphine for patients with opioid use disorder. With respect to privacy and security, there are technology and environmental considerations. Technology considerations include ensuring a secure point-to-point connection, administrative, physical, and technical safeguards for electronic protected health information, using a private high-speed network, compliance with the Health Insurance Portability and Accountability Act, HIPAA, other federal laws and regulations, and state laws, ensuring a fully encrypted data transmission, and contractual assurances such as business associate agreements that third parties will also follow the rules around HIPAA. Environmental considerations include both patient and physician connecting from a private space and physicians and patients letting each other know if there are others in the room or if others enter the room during the encounter. On March 17, 2020, the HHS Office for Civil Rights announced that it will exercise its enforcement discretion and will not impose penalties for non-compliance with the regulatory requirements under the HIPAA rules against covered healthcare providers in connection with good faith provision of telehealth, specifically during the COVID-19 nationwide public health emergency. OCR indicated that under this notice, covered healthcare providers may use popular applications that allow for video chats, including Apple FaceTime, Facebook Messenger video chat, Google Hangouts video, Zoom, or Skype, to provide telehealth without the risk that OCR might seek to impose a penalty for non-compliance with the HIPAA rules related to the good faith provision of telehealth during the public health emergency. OCR indicated that Facebook Live, Twitch, TikTok, and similar public-facing video communication applications should not be used. While this change has temporarily been made at the federal level, one must also consider organization protocols, as well as state laws and regulations regarding health information and what is required to protect it. For more information on legal and regulatory considerations and other telepsychiatry resources, please visit ACAP's website at aacap.org/telepsychiatry. For the Telepsychiatry Toolkit, I'm Dr. Shabana Khan. Thanks for watching.